Purpura, etiology, coagulation assessment, and evidence-based management. Purpura affects approximately 15 per 100,000 individuals annually, with higher incidence in elderly populations. It results from vascular, platelet, or coagulation dysfunction leading to non-blanching hemorrhagic lesions greater than or equal to 3 mm in diameter. Diagnosis hinges on a structured coagulation profile, platelet count, and clinical pattern recognition to differentiate thrombocytopenic from non-thrombocytopenic causes. Management is etiology-specific, ranging from corticosteroids in immune thrombocytopenia, prednisone 1 mg per kilogram per day, to plasma exchange in thrombotic thrombocytopenic purpura, TTP, guided by AHA and ASH guidelines. Key points. Note: Purpura is defined as non-blanching cutaneous hemorrhages greater than or equal to 3 mm in diameter, with an annual incidence of 15 per 100,000 persons. Platelet count 150 × 10/L defines thrombocytopenia and is present in 60 to 70% of purpura cases due to immune thrombocytopenia, ITP, or drug-induced causes. Prothrombin time, PT, greater than 13.5 seconds, normal 11 to 13.5 s, and activated partial thromboplastin time, APTT, greater than 35 seconds, normal 25 to 35 s, suggest coagulation factor deficiency or inhibitor presence. ADAMTS 13 activity less than 10% confirms thrombotic thrombocytopenic purpura, TTP, a medical emergency requiring plasma exchange within 4 to 8 hours of diagnosis. Warfarin-induced skin necrosis typically occurs on day 3 to 5 of therapy, with protein C deficiency as a key risk factor, relative risk 4.2. Henoxin-line purpura, HSP, accounts for 90% of childhood vasculitic purpura, with peak incidence at age 4 to 6 years and male-to-female ratio of 1.5 to 1. Vancomycin-associated thrombocytopenia occurs in 5 to 10% of patients on prolonged therapy, greater than 14 days, with platelet count nadir at day 10 to 14. Corticosteroids, prednisone 1 mg per kilogram per day orally, are first line in ITP, achieving response in 80% of adults within 1 to 2 weeks. Fresh frozen plasma, FFP, is indicated for coagulopathy with active bleeding and INR greater than or equal to 1.8, administered at 15 to 20 ml/kg. Rituximab, 375 mg per square meter 4 weekly times 4 doses, is second line in ITP, with sustained response in 40 to 60% of patients at 6 months. Liver disease with INR greater than 1.5 and platelet count 50 × 10/L increases bleeding risk by 3.8-fold compared to controls. Scurvy, vitamin C deficiency, causes parafollicular purpura and corkscrew hairs, with plasma ascorbic acid less than 11 mol/L diagnostic. Overview and epidemiology. Purpura is defined as non-blanching, palpable or non-palpable cutaneous or mucosal hemorrhages measuring greater than or equal to 3 mm in diameter, resulting from extravasation of blood into the skin or submucosal tissues. The ICD-10 code for purpura, unspecified, is D69.6. Specific subtypes have distinct codes, e.g., D69.0 for allergic purpura, D69.3 for ITP. The annual incidence of purpura is approximately 15 per 100,000 individuals globally, with higher rates in developed nations due to aging populations and increased polypharmacy. In the United States, the incidence of immune thrombocytopenia, ITP, a leading cause of thrombocytopenic purpura, is 3.3 per 100,000 adults and 5.3 per 100,000 children annually. In Europe, the incidence of ITP ranges from 2.5 to 4.0 per 100,000, with a bimodal age distribution, peaks in children aged 2 to 6 years and adults greater than 60 years. Purpura is more common in females than males in ITP, female-to-male ratio 1.7 to 1, whereas thrombotic thrombocytopenic purpura, TTP, shows a 2 to 1 female predominance. Henoxin-line purpura, HSP, predominantly affects children, with 90% of cases occurring between ages 2 and 11 years, peaking at 4 to 6 years, and a male-to-female ratio of 1.5 to 1. Racial disparities exist. African Americans have a 1.8-fold higher risk of developing ITP compared to Caucasians, while HSP is more prevalent in Caucasians and Asians than in African populations. Pathophysiology. Purpura arises from disruption in one or more components of hemostasis, vascular integrity, platelet number/function, or coagulation cascade. Vascular purpura, such as in vasculitis or scurvy, results from endothelial damage or basement membrane fragility. In scurvy, vitamin C deficiency impairs hydroxylation of proline and lysine residues in collagen, reducing collagen cross-linking and increasing capillary fragility. Plasma ascorbic acid less than 11 mol/L leads to parafollicular hemorrhage and purpura, with histology showing capillary dilation and red blood cell extravasation. Thrombocytopenic purpura occurs when platelet counts fall below 150 × 10/L. In immune thrombocytopenia, ITP, autoreactive B cells produce IgG antibodies against platelet glycoproteins IIB/3A or IB/9, leading to Fc receptor-mediated phagocytosis in the spleen. The median platelet turnover in ITP is reduced from normal 7 to 10 days to 1 to 3 days. TTP is caused by deficiency of ADAMTS13, a disintegrin and metalloproteinase with a thrombospondin type 1 motif, member 13, a protease that cleaves ultra-large von Willebrand factor, ULVWF, multimers. ADAMTS13 activity less than 10%, normal greater than 60%, leads to unchecked platelet aggregation and microthrombi, causing mechanical hemolysis, schistocytes in 95% of cases, and end-organ ischemia. In congenital TTP, Upshaw-Schulman syndrome, mutations in the ADAMTS13 gene, chromosome 9q34, result in lifelong deficiency. Clinical presentation. The classic presentation of purpura includes non-blanching, round or irregular macules or patches greater than or equal to 3 mm in diameter, most commonly on dependent areas, lower extremities, buttocks, or trauma-prone sites. In ITP, petechiae and purpura are present in 85% of patients, with mucosal bleeding, epistaxis, gingival, in 40 to 60%. Severe thrombocytopenia, 20 × 10/L, increases risk of intracranial hemorrhage, ICH, to 0.5 to 1% annually. HSP presents with palpable purpura in 100% of cases, typically on lower extremities and buttocks, accompanied by abdominal pain, 65%, arthritis, 75%, and renal involvement, 40%, with hematuria in 30%. The rash appears in crops over 2 to 4 weeks and resolves without scarring. Key points: platelet count 20 × 10/L, risk of spontaneous ICH, 0.5 to 1% per year. Neurological changes with thrombocytopenia, suggests TTP or ICH. INR greater than 4.0 with active bleeding. Purpura fulminans, widespread necrotic purpura, DIC, shock. Diagnosis. Diagnosis of purpura requires a systematic approach integrating history, physical exam, and laboratory testing. The initial workup includes complete blood count, CBC, peripheral smear, PT, APTT, and liver/renal function tests. Step 1. CBC and peripheral smear key points. Platelet count, 150 × 10/L indicates thrombocytopenia. Hemoglobin, less than 10 g/dL suggests bleeding or hemolysis. Peripheral smear, schistocytes greater than 1%, normal less than 0.5%, indicate MAHA, seen in TTP, DIC, or HUS. In ITP, platelets are large and normal in morphology. In TTP, microspherocytes and helmet cells are present. PT, normal 11 to 13.5 seconds. Greater than 13.5 s suggests factor 7 deficiency or warfarin effect. Management and treatment. Immediate stabilization includes airway, breathing, circulation assessment. In active bleeding with platelets 20 times 10/L, platelet transfusion is indicated. 1 unit apheresis platelets or 6 to 8 units pooled platelets increases count by 30 times 10/L. For suspected TTP, plasma exchange, PLEX, must begin within 4 to 8 hours of diagnosis, per American Society of Hematology, ASH, 2019 guidelines. PLEX is performed with 1.0 to 1.5 plasma volumes daily using fresh frozen plasma, FFP, until platelet count 150 times 10/L and LDH normalizes. In warfarin-related bleeding with INR greater than or equal to 1.8, administer 4-factor prothrombin complex concentrate, PCC, at 25 to 50 IU/kg, dose based on INR. 25 IU/kg for INR 2 to 4, 50 IU/kg for INR 6, over 10 to 20 minutes, per ACCP 2021 guidelines. Vitamin K 5 to 10 mg for slowly, over 30 minutes to avoid anaphylactoid reactions, is given concurrently. Key points: vital signs every 15 to 30 minutes in active bleeding. Platelet count every 6 to 12 hours in TTP. INR every 6 hours until stable. Prednisone, 1 mg per kilogram per day orally, max 80 mg per day, for 2 to 4 weeks, then taper over 4 to 6 weeks. Mechanism: suppresses autoantibody production and macrophage phagocytosis. Response in 80% within 1 to 2 weeks. Monitor glucose, risk of. References: 1. Mishra K. et al. Bleeding Risk Assessment in Immune Thrombocytopenia. Annals of Hematology. 2023, 102, 11-3007-3014. PMID, 377400064, https://pubmed.ncbi.nlm.nih.gov/377400064. DOI 10.1007/S00277-023-05466-1. 2. Priam P. et al. Psychiatric Profile and Response to Combined Pharmacologic and Psychotherapeutic Treatment in Psychogenic Purpura. The Primary Care Companion for CNS Disorders. 2021, 23, 4. PMID 34352940, https://pubmed.ncbi.nlm.nih.gov/34352940. DOI 10.4088/PCC.20M02870, 3. et al. Microbe-immune interactions, new perspectives on coagulation deficiencies, purpura, and other hemorrhagic conditions under the regulation of the gut microbiota. Frontiers in Immunology. 2024, 15:14612221. PMID 394398004, https://pubmed.ncbi.nlm.nih.gov/394398004. DOI 10.3389/FIMO.2024.14612221. 4. Marriott E. et al. Performance of diagnostic scores in thrombotic microangiopathy patients in the intensive care unit, a monocentric study. Thrombosis and hemostasis. 2021, 121, 11-1427-1434. PMID 335127005, https://pubmed.ncbi.nlm.nih.gov/33512705. DOI 10.1055/1378-3804. 5. Patel T. et al. Early Diagnosis and Tailored Treatment in Atypical Idiopathic Thrombocytopenic Purpura, a Care-Compliant Case Report. Medicine. 2025, 104, 36E44263. PMID 409222302, https://pubmed.ncbi.nlm.nih.gov/409222302. doi 10.1097/md.0000000000444263. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.